All right, we are on to our fifth of 9 myths about urinary tract infection, and this is a big one. Probably the most common myth of UTI. Does urinary tract infection cause altered mental status? Let me use a case for you. Let's say you've got a 93-year-old female with a history of dementia who comes into the emergency room altered from baseline. First thing you do is obviously remove all weapons, but like a good physician, you then settle into your H&P. As expected, you can't get much history because the patient is altered, right? And you look in every corner of the electronic medical record to find what may be causing this presentation. You find a great list of medical conditions, any of which may explain the encephalopathy, and even though you remember your typical diagnostic approach, you're almost 150% positive that this must be UTI, even before any diagnostics come back. Like, other things are almost impossible. This is a ceftriaxone deficiency state. We all learn to have a broad differential diagnosis in patients presenting with altered mental status, but as soon as we get that urine culture growing 100,000 E. coli, everything else goes out the window and infection becomes our chief suspect. But can anyone just explain this to me? I mean, why? How would bacteria in the urine be enough to disrupt the whole mental equilibrium for a patient? This is a normal state, right? Old people get bacteria. Then why all of a sudden does it cause global cerebral dysfunction? Is it that there's some mystery anatomic connectivity between the urinary bladder and the central nervous system? Is it that there's some sort of silent but magical cytokine response that's enough to cause brain dysfunction, but not enough to cause a fever or hemodynamic instability? What is it? How is it mechanistically that bacteriuria begets encephalopathy? Anyone? Bueller? Well, the answer is that no one has attempted to explain it. I can't find anything on this. It's from old data looking at association between altered mental status and positive urine cultures. But remember, elderly patients get bacteriuria at high rates. It's actually the normal state for many patients. If up to 50% of a population has a finding, that should be considered within the normal spectrum. It's like the presence of a penis. I wouldn't consider a penis to be abnormal. We blame the urinary tract a lot for many elderly-related presentations to the hospital, but guess what? Treatment of the urine with antibiotics, even in patients with fever, does not result in culture clearance. The positive predictive value of urine culture for fever in this population is extremely low. Most guidelines have even shifted away from recommending antibiotics for the treatment of altered mental status in elderly patients with bacteriuria. Shea specifically recommends against treating delirium with antibiotics. IDSA only recommends treatment of UTI with specific symptoms, not non-specific things like AMS. Treatment of asymptomatic bacteriuria is really only justified in pregnant patients and as periop prophylaxis right before a patient's getting an invasive urologic procedure. Though I acknowledge there's actually ongoing debate around renal transplant, and the shortening of the window around transplant seems to be changing. But even the Geriatric Society guidelines here are following suit with these Infectious Disease Society guidelines. McGeer criteria do not recommend screening urine in delirious patients, even when febrile, with a leukocytosis. This same sentiment is shared by multiple other interdisciplinary groups. Altered mental status is not a specific finding related to the urinary tract. Even if a patient can't tell you that they're having dysuria, there is no indication for antibiotics. I hear that a lot. Well, how do I know if the patient has the symptoms if they can't tell me that they have symptoms? But remember, the benefit of antibiotics is not to avoid risk of ascending infection. There is no data that antibiotics prevent pyelonephritis. The benefit of antibiotics is to relieve symptoms. And if they can't complain of symptoms, what are you trying to alleviate? What is your endpoint? In the list of the top 10 things that rehab docs should question, urine cultures are number 3. The finding of bacteria may lead to erroneous assumptions about the cause of a patient's delirium. They even suggest that dysuria alone needs corroboration with another finding, like frequency, urgency, suprapubic pain, or gross hematuria. In this patient population, we need to have a much higher threshold for sending urine to avoid anchoring bias and attempting to identify other reversible causes. This probably feels uncomfortable to most people listening right now. I certainly learned that urine was the most common culprit for delirium, and it was actually an easy admit when those patients came in. This teaching has been perpetuated through time because of a very broad retrospective evidence base highlighting an association between delirium and bacteriuria. You have to be super careful with how you define UTI. Many use that term to simply just mean bacteriuria, but remember, bacteriuria is much different from a condition that requires antibiotics, which I would define as quote-unquote UTI. It is rare in these situations and in these studies that they actually define UTI in their methods, and when they do, it's almost always just bacteriuria. Almost all of these studies have many problems, but there's a lot of confounding, usually no control groups. They do not suggest if alternative causes of fever are present. And remember, simple cystitis should not cause fever by definition. They do not explain if other interventions are done at the same time. When patients come in with delirium, it's actually common to do multiple things, right? We give them a small bolus, adjust their meds, check for interactions, treat their pain, expose them to daylights, etc. Somehow, despite all of those things that we're doing, we still attribute the ceftriaxone to the patient's improvement. It's a prime example of the fallacy that antibiotics are magical and fix ambiguous situations. Remember, association is not causation. Appropriately designed trials to remove this bias may help, but are there any out there? Well, in one study from 2017 that looked at the prospective treatment versus non-treatment of asymptomatic bacteria in delirious patients, patients who received antibiotics actually had worse outcomes. They had worse functional outcome than those who were not given antibiotics and, as you would expect, developed C. diff at higher rates. Antibiotics are not benign. The problem is that confirmation bias has pushed this practice forward. I associate delirium with bacteriuria. I give ceftriaxone. I get patient better. I good doctor. But was it really the ceftriaxone that got the patient better? Or was it all the other stuff that I did as part of my altered mental status treatment package instead? Inevitably, this selects out for internal treatment protocols that include antibiotics targeting the urine into an improvement motif that we use. But this has a flaw. I associate delirium also with having messed up hair. Patients always come in with messed up hair. I prescribe hairstyling. I get patient better. I good doctor. But was it really the Q4-hour hair brushings that helped? Just because someone gets better after you give them an antibiotic doesn't mean it was actually the antibiotic that made them better. Studies actually suggest the opposite. So then how do you make the diagnosis of a urinary tract infection in an elderly person when the prevalence of bacteria is so common? Well, the suggested approach is much more complicated than a 30-year-old female because of the potential for false positives. You need symptoms and microbiology. Symptoms. You need to have either dysuria or two other urinary symptoms, since all other urinary symptoms outside of dysuria are less specific. If you have fever or leukocytosis, then you only need one of those less specific symptoms. But note here that altered mental status is not listed as a symptom in the diagnostic criteria. For microbiology, you really need to have significant non-polymicrobial growth. A Foley complicates things. With a Foley, symptoms are less reliable. If delirium is encountered, you need to rule out other causes of that delirium first and have a leukocytosis. So it's hard to make it even in the situation of a Foley, even though it becomes a little bit less challenging there. I was taught in medical school that UTI was a cause of delirium and needed antibiotics, but the lie detector said that that was a lie. Yes, old people get altered. Yes, they also have bacteria at high rates. Yes, they get better over time in situations where antibiotics are given, but they also get better over time regardless. Prospective studies have not shown benefit, and all guidelines recommend avoiding urine culture in the setting of delirium due to potential confounding, creation of drug-resistant organisms, antibiotic side effects, and missed opportunities to diagnose the true etiology in a timely fashion. Address other etiologies in your differential before culturing and targeting urine in clinically stable non-septic patients. This was the fifth in a series of lectures that you can find at our Viper YouTube channel. take a listen to our other 9 myths about urinary tract infection that get mistaught in medical school, and let me know if you have questions.